Hello everyone. So today we are going to see about Phakomatosis, and to start with I am starting with Phenylketonuria. Before going into the details about phenylketonuria, one should know how phenylalanine is metabolized. Phenylalanine is metabolized by phenylalanine hydroxylase to tyrosine. Tyrosine will be metabolized by tyrosine hydroxylase to levodopa. Levodopa will be converted by dopa decarboxylase into dopamine, and dopamine will get converted by dopamine beta hydroxylase into epinephrine. Epinephrine will finally be converted to norepinephrine by phentolamine N-methyl transferase, which is abbreviated as PNMT. So this is the basics that one should know. In phenylketonuria, the phenylalanine hydroxylase is absent. If phenylalanine hydroxylase is not there, then there is accumulation of phenylalanine. There are many problems because of accumulation of phenylalanine. One should also know that along with accumulation of phenylalanine, the tyrosine is not formed, isn't it? Since the phenylalanine hydroxylase is not present, the tyrosine will get converted to melanin with the enzyme tyrosinase. This is also important. So therefore, along with accumulation of phenylalanine, there will also not be melanin. Therefore, those affected with phenylketonuria, like due to the absence of phenylalanine hydroxylase, will be fair skinned. In addition to this, in the USMLE, the questions will also be targeted towards dopamine beta hydroxylase. Like how will the question be? They will be asking like 15-year-old male who has an intermittent orthostatic hypotension with low serum epinephrine concentration. So why is there is low serum epinephrine concentration? This is because of the absence of dopamine beta hydroxylase and high serum dopamine concentrations. Obviously, since this enzyme is absent, therefore the precursor product is in high concentration. So what is the enzyme that is deficient? The deficient enzyme is dopamine beta hydroxylase. Why should there be orthostatic hypotension? Because epinephrine and norepinephrine are very much important to maintain our blood pressure. So therefore, absence of this will result in intermittent orthostatic hypotension. In addition to it, there is something known as malignant variant of this phenylketonuria. That is because there is a cofactor. Apart from phenylalanine hydroxylase, the body also needs tetrahydrobiopterin to convert phenylalanine to tyrosine. If the body doesn't have phenylalanine hydroxylase, or if it doesn't have tetrahydrobiopterin, then phenylalanine is not getting converted to tyrosine. Phenylalanine accumulates, and that will also present with the similar feature of phenylketonuria. Therefore, that is known as the malignant variety. So here the question will be focusing on, they will not be giving you all these enzymes, but they will be giving you cofactors and certain other substrates. So therefore, we have to be aware that the tetrahydrobiopterin is necessary for the conversion of phenylalanine to tyrosine, and also for tyrosine to levodopa. Levodopa to dopamine, there is vitamin B6 is necessary. Dopamine to epinephrine, vitamin C is necessary. Now let's see what is the clinical presentation of phenylketonuria. The fair skin, because of the absence of melanin production, and they will be also having a distinctive musty or a mousy odor. In the child will be having this kind of odor in it, and they will also be having a development delay. This is because the phenylalanine will affect the brain function. Therefore, this will result in a development delay. These are the three important features of phenylketonuria. The newborn screening is that a routine newborn screening is crucial for the early detection. So once it is phenylketonuria is detected early, then we can avoid the food which are containing phenylalanine, thereby preventing the symptoms of phenylketonuria. So how is it early detected? The heel prick test, which is conducted shortly after birth, checks for elevated phenylalanine levels in the blood, and therefore it will indicate PKU, and thereby we can prevent phenylketonuria. So how will the question be asked? Newborn screening is critical for early detection and prevention of PKU, right? So this is how they will ask you the question. 6-month-old boy with a musty or mousy body odor and who has a fairer skin compared to siblings, also has a slow mental progression. Question will ask, how can this condition be prevented? The answer is this knowledge will help you to answer that question. Routine newborn screening. Diagnosis is phenylketonuria, which is picked up on heel prick test at birth. So the treatment of phenylketonuria involves a strict diet which is low in phenylalanine to prevent the buildup and minimize the neurological damage. What is a malignant PKU? That is also an increase in serum phenylalanine, but it is because of a deficiency of the cofactor for phenylalanine hydroxylase, which is tetrahydrobiopterin, THB. So, 1-month-old child with increased serum phenylalanine. Question asked, what is deficient in this patient? So, the answer will be all substrates and cofactors, for which we have to choose either tetrahydrobiopterin or hydrobiopterin, THB or HBH4. This is known as malignant PKU. What is about tuberous sclerosis? Tuberous sclerosis is a genetic disorder that we should know, and it is because of the defect in it is an autosomal dominant disorder, and it is because of the defect in the chromosomes 9 as well as the 16 with mutations in the hamartin and tuberin proteins. So this is what is the genetic basis for tuberous sclerosis. Those who are suffering from tuberous sclerosis will have flesh colored papules on the bridge of the nose as well as on the nasolabial folds. This is a common finding in tuberous sclerosis. Apart from this finding, they will also they will be having seizures. The patients with tuberous sclerosis will be having seizures, which can be denoted in the exams like there will be a writhing movement during sleep, which can be a sign of the seizures. And they will also have cardiac rhabdomyoma, renal angiomyolipoma. So if you can detect a patient who is having a tuberous sclerosis, then screening should be done for cardiac rhabdomyoma, renal angiomyolipoma, as well as subungual fibroids, which are the snail bed growth is known as subungual fibromas. And the characteristic skin lesions will be ash leaf spots as well as shagreen patches. So the question will be oriented like a 20-year-old male with a 6-year history of seizure disorder, and they also have a flesh colored papules on the bridge of the nose and in the nasolabial fold. What is the diagnosis? Diagnosis is tuberous sclerosis. The second one which we are going to see is neurofibromatosis type 1 and neurofibromatosis type 2. Let me tell you first about neurofibromatosis type 2. Type 2 is basically it has bilateral acoustic schwannomas as well as meningiomas. But whereas in neurofibromatosis type 1, it is characterized by neurofibromas, it is characterized by café spots, it is characterized by axillary or the groin freckling, leash nodules, and potential complications such as optic nerve glioma, pheochromocytoma, and many other tumors. So I would suggest you to remember neurofibromatosis type 2, which is much easier, and the rest of the clinical features are attributed to neurofibromatosis type 1. Just to make certain things clear about tuberous sclerosis, which we saw in the previous slide, it is because of 2 chromosomes. Tuberous sclerosis 1 is because of the chromosome 9 and tuberous sclerosis 2 is because of the chromosome number 16. And I told you that they will be presenting with the seizures, which the question will be telling like that they will be having a writhing movement of the hand when they sleep. So that is why should they have seizures? It is because of tubers. As the name says, there are tubers or periventricular nodules or the tubers on the MRI, which will be resulting in a seizures. What do we know about von Hippel-Lindau syndrome? Von Hippel-Lindau syndrome is the most common thing is renal cell carcinoma. The kidney dysfunction happens. It is a autosomal dominant, which is because of chromosome number 3. So during my early stages, I used to remember that von Hippel-Lindau, VHL. So when abbreviated, so therefore it is chromosome number 3. I'm not sure whether this is useful, just a small tip. In addition to it, there is a mutation which leads to constitutive activation of hypoxia inducible factor, contributing to tumor growth and development. There are in von Hippel-Lindau syndrome, along with bilateral renal cell carcinoma, there will also be cerebellar and retinal hemangioblastomas, as well as pancreatic cysts are also present. Sturge-Weber, an important thing about Sturge-Weber is that it doesn't have a genetic basis. It is because of a spontaneous mutation. That is what we should know. All the other diseases which we saw are due to genetic reasons, but this has a spontaneous mutation. Prominent feature of Sturge-Weber is Port wine stain, which is often present at the birth. And leptomeningeal angioma, that is a vascular malformation in the brain which is associated with the seizures. And there will also be affecting the eye, and there will be potential loss of vision in those who are suffering from Sturge syndrome. Thank you for listening all this while. I am happy that you have come to the end of the slide. I hope this is helpful to you. If you have any questions, you can write to me. I am more than happy to clear all your doubts. I have an announcement for you. I am starting my mentoring lessons for medical graduates and USMLE aspirants. If you like my videos and if you like the way I teach, you can sign up for my mentoring class. I can't wait to see you succeed. Thank you. Have a good day.